Thank you. Thank you for the kind introduction and the invitation. It's been a pleasure to listen to all the talks so far, and thank you all for your patience in staying on. So, as you mentioned, I'm going to be focusing on cities, and particularly in the rapidly growing context, and I'll give you the rationale for why. So, if we just start with urbanization and health today, based on what we know as from a global perspective. This is from the 2018 World Urbanization Prospects Report, and essentially plotting the projections of growth of urban populations across the different regions of the world. And what you can see is that whilst, for example, you see higher baselines in North America and Europe and also in Asia, the growth really that we're seeing is happening, that we're going to be seeing for the next or projected 30 years, is happening in Asia and Africa. To give you further context, just to get a sense of how fast these cities are growing, this image shows the hourly growth of people moving into cities across the world. So this is number of people coming to cities per hour. I'm in London at the moment, and you can see that's 10 people per hour. It's 11 in New York, compared to 56 in Lagos, 75 in Delhi, 60 in Beijing, 60 in Dhaka. So you really start to get a sense of how dynamic these cities are, and why it's so important to think about health in these contexts in order to address global health generally. Moving specifically to planetary health, which essentially talks about that balance between the human health and activities and the natural ecosystems that we depend on. What we can see here is we have significant implications of urbanization, both urbanization and climate change, by the way, but I'm focusing on urbanization. If we picture this, this triangle between the environment, hosts as us humans, and contagions, be that pathogens like COVID or pollutants like air pollution, we can start to see the interaction. So we play a role, the interaction, the links between contagious and environment really are impacted by our activities, be that encroaching into ecosystems that increase the likelihood of emergence of novel pathogens, the interaction between us and the environment, is impacted by the presence of a contagion and in terms of transmission of disease, etc. And similarly, our vulnerability to any contagion we're exposed to is very much determined by the environments that we are exposed to. So in that context, it's really not a surprise that we see this health inequality playing out globally, particularly in the context of cities, because we are seeing rapidly growing cities that are disrupt ecology by necessity, pushing the boundaries of human settlements. We're seeing built environments that facilitate transmission of disease. So in the context of dense settlements, we're seeing increased vulnerability to disease, both from exposure to your unhealthy environments, like, we know, for example, obesity and COVID, etc., but also through inadequate infrastructure for water and sanitation. And lastly, we also have this inequitable access to care. So we're starting to see the precarities of what existed before COVID. Now, whilst we obviously have COVID on mind, and I talking about post-COVID reset and new norms, I want to challenge us a little bit in that vein. So I'm going to pose some questions here, and you can reflect on whether I'm talking about COVID or whether this actually could be hypertension, or indeed whether this could be HIV. So if we said there was a contagion that had borderless risk exposures and threats, that hit adults who are otherwise healthy, that affects more than the marginalized, but we see increased risk with deprivation, that has overwhelming impact at community scale, but even more disastrous at a macro and global scale. It has a long time arc of its impact on society, And that is a higher risk with urban mobility and migration. And the critical thing really is that it could be any of those. And so we start to see why the vulnerabilities that we have set up in the ways that we've constructed society are so dangerous, not just for human health, but for planetary health, and certainly not just for COVID. Further exemplifying is in the context of South Africa, where I've worked for a long time and continue to be affiliated. These are the risk factors that contribute to morbidity, so disability adjusted life years. In 1990, we had the top 10 were undernutrition, unsafe water, unsafe sanitation, hand washing, etc. Fast forward 25 years or so, and with development, with urbanization, we see a rapid change, quite marked change in the factors contributing to morbidity, with unsafe sex due to the HIV epidemic, but also seeing high body mass index, high blood glucose, obviously related to diabetes, blood pressure, etc. So significantly changed. When you look at those, the top 10 of those factors interact with risks that we know today associated with COVID susceptibility and severity, be that with respect to the illness itself or ability to effectively take up advice and control measures. So that really, we're starting to get a broader sense of the societal vulnerabilities and why it's so critical to rethink what we mean by creating health, and why it's so fundamental to reimagine the urban as part of that. So further, why of this rethink? Often when we think about health, and when we talk about health, we often default into healthcare. But actually, we know that we're unable to treat ourselves solely through this or any epidemic. So the example, going back to South Africa, there's been some costing done looking at just cardiovascular disease, and the cost of treating cardiovascular disease just to the primary care level, so not tertiary care, but just to the primary care level, optimally would bankrupt the entire healthcare system, just for one set of diseases. So we have to start thinking beyond just trying to catch up and spend more and more on healthcare, which is needed, but we have to move upstream and think about the majority of factors that lie outside of healthcare. We know that almost 80% of factors that influence disease and health lie outside of healthcare, and really move into that primary prevention space. So what would that rethink look like? As I mentioned, we normally think about health services. When we talk about the health services, we think about healthcare, be that for prophylaxis like vaccines or treatments or palliative care. We think about exposures to those health services, how available they are, etc., and the medium and long-term impacts related to disease control and mortality. But what if we thought differently about what a health service was in that context? And what if we thought about human settlements and planning as a health service, given that we know exposures like damp and ventilation, air pollution, indoor air pollution impacts your ability to be physically active, your obesity risk, and down the line, your respiratory disease risk, cardiovascular risk, and mental health? What if we thought about transport as a health service, given those exposures and the downstream impact on health? Or water and waste sanitation and management, or food, in fact. So how do we start thinking differently about what it takes, the services it takes to create health beyond solely thinking about healthcare? And in what ways can we harness those urban exposures that can often be detrimental and undermine health to positively influence and create health? If we try to map that system onto COVID. So building on from that narrative, when I talk about systems, I don't talk about health systems because those are often kind of narrow limited to healthcare systems, but I talk about systems for health. So if we looked at the COVID systems for health, this is what it would look like, right? I've consciously not tried to make this any cleaner because it is complex, and we do have to engage with that complexity. So if we look, for example, at the known associations between these infrastructure services, exposures, and downstream behaviors and health outcomes, we can see, tracing back up from a disease like COVID, the vulnerability factors like asthma, diabetes, obesity have a myriad of known associations with behaviors and exposures, including healthcare access, but far beyond that. And importantly, transmission factors are also span across infrastructure that would require engagement with thinking about transport, thinking about how we use land to create health in a way that is done sustainably. So hopefully I'm giving a bit of an argument for why we need to address systemic drivers for factors that influence health, particularly in the context of preventability, because that's the other thing I want to highlight here, because we often think about health once we have lost health, but often a lot of the determinants and the drivers are preventable if we're able to think upstream. And critically, we have to recognize that health doesn't just trickle down from good intentions, and we have to think consciously and proactively about prevention. But here's the thing, when it's been spoken about a little bit today in the context of risk perceptions, some of the things that challenge us are acting when the cause and effect are not side by side. So would we have galvanized so effectively for the COVID pandemic if exposure to the virus in London created disease 3 months down the line in Lagos? Or would that slow us down? If we're able to carry on as normal to some extent, we're less likely to perceive this as something high risk and something that needs to be addressed as a matter of urgency. And if we can other the consequence and say, well, you know, we're doing good, the consequence, it's healthcare's responsibility. So that perception of risk limits action sometimes. It's easier to be active when the ask is finite and clear, and when it doesn't require structural long-term change, and when the benefit can be accredited to me. So if I do something, I'm accredited. And what we can see with the COVID pandemic is that the call to action really is not finite and clear, requires very structural long-term change if we are to really learn the foundational lessons that we've learned here in terms of how we're structuring society. And often the benefits cannot be attributed to a single responder. So thinking differently, we have to recognize firstly that resilience is not an endpoint. And we often talk about, you know, we're trying to make things resilient, where actually resilience is also not not purely reactive, but internalizing the fact that many of the shocks and stresses that I've just explained actually stem from intentional choices, unintended but intentional choices by different actors from local to global, and that building resilience has to confront those. We will have to tackle the problem blindness, and part of the reason I show that complex diagram of the systems for health is often it's very easy to not see the problem when there is a disconnect either in time and or space between exposure to a risk pathogen or pollutant and an outcome. Examples are things like air pollution, and we see that in the context of in Asia with the wildfires and how those know no boundaries. And the challenges are blurred lines of accountability. So who is responsible for health if we are not able to connect exposures and outcomes? And lastly, and importantly, the wrong pocket problem, where addressing it requires investing in the social, economic, and environmental determinants of health, where the benefit does not necessarily accrue to the particular sector that creates the most health. So we need to think differently when we start talking about what does it mean to finance health, thinking beyond these silos. So This is the last part of my talk. I end with the call to action and some of the work that I've been kind of thinking through as a Marshall Plan, if you like, for planetary health in Africa. So there's two important factors. Obviously, Africa is a very diverse continent, but there's two almost homogeneous factors that we see play out across the continent. The first is that we're urban and increasingly urbanizing. So one of the fastest urbanizing regions in the world, as I showed at the beginning, and that we're young, which Prof. Hassan mentioned earlier. And so these are potential both challenges and opportunities. So urbanization is, I've shown the ways in which exposures can influence health. It also creates a space to create health, particularly in the context of environments changing so rapidly with fast growth. But unfortunately, at the moment, we don't have goals that are aligned for health and sustainability. And the scaling, particularly because the scaling of these interventions needs commitments across sectors, not just thinking about healthcare. And secondly, with the perspective of the youth, the important target population, because the other thing we haven't mentioned is the intergenerational aspect of, exposures today in the young impact their future health and the future health of the future generation. But beyond as a target population, they're also important agents of societal change. And we've seen that in the context of advocacy around climate change globally. So bringing those two together, we have these cities of young people that are places of hope. And the recent survey has shown, and hope was mentioned earlier, rising Afro-optimism much more than any other region, driven by a sense of responsibility, entrepreneurship, and confidence in an African identity. And the critical thing is not resting on laurels, but working out how we can harness this hope as an important ingredient of driving change to create health equitably and sustainably. So what if, in thinking about health, we ask questions like, how can we increase the supply of health from place? In other words, how can we centralize health as key to sustainable urban development, to prevent those preventable emergencies? So we're not just waiting for emergencies, acting as though there's nothing we could have done about them now. And that really requires us thinking about designing health and integrating health into the ways that we think about cities. I really appreciated the point that was made at the start, the first speaker, around strategic science, and we need that emergency strategic science, because there's never space or time to settle down and think about the long term. What actually needs to happen now. And secondly, what if we could increase that demand and change accountability for health? And that involves both raising awareness of the importance of the environment for health and human and planetary health, and also raising and fostering accountability for making a healthy choice an easy one. And I believe underlying all of this, as is mentioned, obviously we're in an academy of science, strongly science-based, but the principles have to be equity-centered. In the context of Africa, it has to be youth privilege. We can't be designing and thinking about cities and health and then thinking about youth as an afterthought. We actually have to have youth-driven, youth-led and perspectives on creating health. And so it's immediately apparent that we have to address social, economic, and political determinants of health. And this is something that has is ever more obvious and revealed through the COVID pandemic. It is clear that it's not restricted to the health sector, but we need unprecedented and sustained collaboration and cooperation. These kinds of cooperations across sectors that have been brought together for the COVID pandemic. This is not a temporary state of affairs going back to normal and siloed, because a lot of the challenges of preventable health emergencies are driven by those silos. And we need to avoid the short-sighted focus on development and detriment to health, as much as health as detriment to ecological boundaries. So this is really just a couple of things I'd written earlier, and just to finish off, pushing for us to rethink not just health and not just urban, but to rethink what we mean by emergencies, and really thinking about how we can galvanize that sense of urgency that we feel now for COVID for a more sustained long-term approach to planetary health. But that will require a few things, and some of which have been touched on on earlier, really underlying this clear leadership and a mandate, really informed by evidence and data on this, intersectoral collaboration, as I mentioned, cross-cutting measurements of health and resilience as a performance indicator across all of society, and that integrated measurement for accountability. And I will end, this is my last slide, that the last thing that I think would be really critical, we've talked about hope, we've talked about love, we've talked about, but the one thing that we really need to profile as well is trust. And I think as scientists, we need to not wait for moments of crisis to try and engage public in science, because that element of trust and building that trust starts when we don't feel that sense of crisis. But this will require an engaged pipeline of diverse scientists. We talked about science advice earlier. Not only do we require diverse disciplines, but the different perspectives. We've seen the potentially detrimental impact of science advice when it is either monodisciplined or involves people with a similar shared experience and not diverse. And we've had examples of, like the Global Young Academy, really engaging in that space. And the last thing I would say really is that there is a call for us in the academic institutions as well, because we talk about this, we talk about the importance of reaching public with science, we talk about this engagement in service society, but we don't value it sufficiently as academia. And we really need to hold ourselves accountable to say, if we want the next generation, and if we want an engaged pipeline of scientists who are prepared to serve and understand how to reach out, then we really have to make that an integral part of how we train scientists for the future. So I'll end there. Thank you.